We'll take about embryo implantation process. We
Yes.
all know that nowadays FETs are more common than
Mhm.
fresh transfers. But in some cases, doctors are still advising patients for fresh transfer. So, what are such conditions where doctor advise that please go ahead with fresh transfer, and what are the conditions when doctor opt for frozen embryo transfer?
Yeah, yes, there are certain conditions where you can go only for frozen transfer. This is like a fad thing, freeze all. The most of the clinics are now telling we are doing freeze all for everyone, but it is
Hmm.
not freeze all for everyone. It is freezing for patients who are indicated. Otherwise, you don't have to freeze all the embryos and do a frozen transfer each and everyone. Like especially the most common indication where you have to do freeze all is in polycystic ovary when they develop hyperstimulation, like in PCOD, because we know a lot of patients have polycystic ovary, maybe 50 to 60% of our IVF cycle patients are PCOD, so they have this
Hmm.
tendency to go in for hyperstimulation. If we give a very less dose also, they produce more number of eggs. In such case, hyperstimulation is very very risky to the patient, so we cannot do a transfer in such case. So in such patients, obviously it is a freeze all, and that will improve their implantation also, and it is a safety concern also, because if you go and do the transfer, they may develop hyperstimulation, clotting disorder, all those things. So we don't want to enter into complications, because it is a elective procedure and we want the patient safety is the foremost thing in this. Whatever treatment we do, safety is the foremost thing. So for safety, OHSs you do freeze all. And in sometimes when the hormones are very high, like the estrogen, the progesterone, sometimes early rise of progesterone is there in for some patients, so the endometrium may not be ideal at that time. There will be an advancement of the endometrium. So, and there is a particular, the window of implantation is very very small, like maybe 3 to 4 days is the exact window of implantation where if you put the embryo it will implant. So if it is an out of phase endometrium or a early rise of progesterone, then also we go in for freeze off. And another one is if the endometrial lining is not good, like if we are doing a fresh cycle and the lining is not up to the mark, in such cases also we can freeze the embryos and we can do a later frozen cycle. We can improve the endometrium. So there are few indications where you do freeze-all, or in failure patients, like they have done several fresh transfers which has failed, so in such patients we can give a chance of a frozen transfer. So otherwise, for a normal patient, if the hormones are normal, if there is no hyperstimulation, the endometrium is good, you can go and do a fresh transfer. It will save the cost, it will save the time to pregnancy also, because in frozen anyway they have to wait for 1 or 2 months. So there are
Hmm.
certain many advantages of fresh transfers. Of course, the cost of freezing thawing is not there, and also the time to pregnancy, that is also very very important. So that is also saved if you do a fresh transfer. So only in indicated cases you do freeze all, otherwise not for all patients. Sometimes patients all say, okay, we want frozen. Another thing
Yes.
is in dual stimulation. If you're doing dual stimulation in patients for a poor reserve, if patients have got less reserve, we do two stimulation in the same cycle. So in such case only, then also we can do a frozen transfer, because we can pool the embryos and do a frozen cycle. So there are certain indications for a normal responding patient, we don't have to do a frozen transfer, we can do a
True.
fresh transfer.
And Dr. Lakshmi, one thing nowadays, like patients are discussing about this successive transfer, like day three transfer, and again
Yes,
after a day,
sequential,
day
yeah,
five,
sequential.
sequential,
Yeah,
sorry. Hmm. So,
sequential.
what,
Yeah.
why doctor suggests this, and is there any, like we can say that advantage of this type of transfer?
Actually, but I'm not so much of a promoter of a sequential transfer. We, in our career, have not done sequential transfer for patients. Like, okay, but this is for like recurrent failure patients. Maybe they are doing sequential transfer, and they may not be knowing that this patient may develop a blastocyst also. Sometimes what they do is they'll do a few 1 or 2 embryo transfer on day 3, and they'll culture the other embryos for the blastocyst. So if the blastocyst doesn't form, also they have a chance of transfer.
Right.
Or if they don't have a blastocyst, okay, day 3 we have already transferred. Or if we are keeping all the embryos of blastocyst, sometimes it may not form, so then the patient will lose the chance of transfer. So that is one advantage. Otherwise, also some clinics are doing sequential transfer. They say that there is an increased chance of implantation, but studies and all evidence is not showing so much high chance for sequential transfer. Matlab, more chance of implantation is not there for, that's what evidence says. But okay, people are trying it for recurrent failures, like they can try sequential transfer. Sequential transfer is you do day 2 or 3 embryos on day 2, and then we do one blastocyst transfer on day 5 in the same cycle. So that's sequential transfer. What we believe is like we can do either a day 3 transfer or a day 5 transfer. So if you're sure that the patient is going to have blastosis, then we might as well do a day 5 transfer.
Right. And Dr. Lakshmi, one very important thing that, like nowadays, people are saying कि it's always better to go ahead with only